Yeah, so this is an EORTC 1414 PEGASUS trial. It's a trial randomized phase 3 clinical trial, multi-center in Europe, randomizing patients with locally advanced disease, having high-risk prostate cancer, to receive radiotherapy combined with GnRH agonist versus antagonist, with a different duration between 18 to 36 months. The background is that androgen deprivation combined with radiotherapy is certainly one of the standard of care treatments for high-risk prostate cancer. And androgen deprivation could be done using agonist or antagonist. And antagonists, based on previous literature, have the advantage to probably decrease the risk of cardiovascular events in patients having previous cardiovascular events, and to have also a lower impact in patients in urinary function, in patients having lower urinary tract symptoms, and probably to have a better decrease in terms of PSA. This is the rationale why when the study was conceived in 2017, so we started in 2017, the goal was to observe if antagonists, in this case the GnRH, could improve these outcomes in patients with high-risk prostate cancer compared to standard of care agonist. Yeah, this was a superiority phase 3 randomized clinical trial. Patient with 2 or more high-risk factors, has PSA of 20 or more, T3 or more disease, CN1, and high Gleason scores like 8 or more, were randomized to receive between 80 to 36 months of agonist versus antagonist. So the primary endpoint at this time was progression-free survival. Then we had to do the problems that we had in accrual. We had to interrupt the trial, and finally we decided to change in terms of primary endpoint for PSA response during the first 6 months after the radiotherapy. And we know, based on the ICECAP group, that achieving a PSA of 0.1 or less at 6 months is a prognostic factor for metastasis-free survival. So it means that we changed the primary endpoint due to the poor accrual of the trial, and these are the results that we are presenting now as primary, and PFS in this case was the secondary endpoint. So finally, what we observe is that in the more than 370 patients that we included in the trial, there were no differences in terms of PSA response, so between the agonist versus antagonist. Even in terms of PFS, overall survival, there was no major differences. Of course, the study was not powered to assess this difference as we change of primary endpoint. The treatment was well tolerated globally, so we had the same rates of side effects between patient receiving agonist versus antagonist. There was no major impact in terms of urinary function, so even in patients with previous symptoms. But what we observe, the observation that we had is that in patients having previous cardiovascular events, the antagonist was associated to a lower risk to develop some cardiovascular events in the follow-up. And we had 2 cases related of cardiovascular-related death that were observed in the agonist arm. Of course, the numbers are really limited, so we cannot have a strong conclusion on that, but there was the observation that we had. On the other hand, in patients without previous cardiovascular events, there were no difference between agonist versus antagonist. So I think that the study tells us that based also on the previous literature that we have, the use of antagonists should be considered in patients having previous cardiovascular events. Of course, based on our trial, we don't have an evidence that we are more efficient in terms of disease control, but probably we have an impact in reducing this type of toxicity. And on the other hand, we have the evidence that overall antagonists were quite well tolerated. We have really few number of patients switching to agonist. So this is another conclusion that is important. Then in the meanwhile, we know that for this patient having a very high-risk disease, so like a very high PSA Gleason score, PSA high Gleason scores, or CN1 disease, now the new standard of care is to use ADT for 3 years combined with abiraterone based on sensitivity data. So, of course, the paradigm has been changed from the start of the trial, but we have this information on the efficacy, tolerance, and also possible reduction in terms of cardiovascular events in patients having previous cardiovascular history.